Hello,
Hello there.
how you
Good
doing?
morning. I'm doing well. I'm so glad to finally be able to do this conversation. So thank you
Same
so much for
here.
joining me. Thank you so much. And are you seeing patients today?
Yes, I am.
Yeah.
I'm in between patients, but we're good.
Yeah.
We're good.
Good, good. Okay. So we have about 45
Yes.
minutes, right?
Yep.
This is Dr. Chinedu Nwabuobi. You just got your board certification for MFM, right?
Yes, I did.
Congratulations. I saw that. I remember when
Thank you
that
very
happened for
much.
me. So it's a big
Yes.
milestone. So now you
It's
are double
huge.
board certified OBGYN and
Yes.
MFM. Now,
Yes. Thank
we
you.
had
Thank you.
many, you have many more years of maintenance of certification, but that's beside the point.
So
But,
true.
the worst part is over. So,
It's over.
okay.
Exactly.
So let's
Exactly.
let's jump right into this discussion. So I've been wanting to
Yes.
do this for a while. I have educated a little bit about the CDC Hear Her campaign. It is excellent. They don't promote it enough,
Mm-mm.
and
No.
they don't. The CDC actually
No.
doesn't promote hardly anything enough. It's a great resource for just about anything, actually.
Yes.
But the Hear Her campaign was born out of the high maternal mortality rate that we have here in the United States. What we're going to do right now is we're going to discuss what they call urgent maternal warning signs. Um,
Correct.
and what most people don't know is that people can have complications related to pregnancy and even death up to a year after they deliver. A year after they deliver.
Correct.
So a lot of these things will apply up to a year after you deliver. So let's just hit it. Let's talk about a headache that won't go away or gets worse over time. Dr. Nabobi, what could that be an indication of?
So, generally speaking, it's not unusual to have headaches in pregnancy,
Right.
first of all. So let's acknowledge the normal things that can happen. However, whenever something persists,
Mm-hmm.
that you start worrying, could there be more to this? Now you start thinking about a headache that could not go away. When you apply it to the appropriate gestational age, you start thinking about things like preeclampsia, right? Very common condition in pregnancy that can cause a lot of harm to mom and to baby. You can even start discussing, go as far as things like brain tumor, okay,
Mm-hmm.
some kind of intracranial process. You can even start thinking about things like an aneurysm, okay.
Mm-hmm.
Now we're taking it to like, possible worst of the worst. But these are things that generally that you do not want to ignore. Can it also be a migraine? Absolutely. Do people
Mm-hmm.
have new onset migraine in pregnancy that they did not have before? But one thing that we are trying to avoid here is missing those things that can cause huge harm to mom or to baby. So you definitely want to have that conversation with your OB provider.
Right. I think that it's important to know that you can be preeclamptic after you deliver without having had preeclampsia in pregnancy. There is such a thing as
Yes.
postpartum preeclampsia. And most often will
Yes.
occur within the first 2 weeks, but I've seen it as late as 4 weeks. That's kind
Yes.
of unusual. But one thing
Yes.
that I tell patients about their headaches, especially the ones who have a history of having headaches, you kind of know, and I'll give myself as an example. I have suffered
Mm.
from migraines my entire life. So when I was pregnant, I know what my migraines are like. And I tell a patient, is this like what you normally have?
Mm.
Is this one of your typical headaches or is it different? And if it's different, how
Yes.
so?
Yes.
So that we know those who have a history of having headaches, whether it be migraines or a headache from another reason, that we know this is different. So that's the
Correct.
first thing that needs to be investigated is if it's different. And then also, you always try, if you have headache in pregnancy, you try increasing your fluid intake, taking some
Correct.
Tylenol. If it doesn't get better with those conservative measures, then you need to let somebody know and you need to be evaluated. A lot of
Yes.
times once we get you into the hospital, what's one of the first things we do when someone complains of a headache when they come into triage when they're pregnant?
You check blood pressures.
Mm-hmm.
You what is it called? You say, have you taken Tylenol before? Can we
Yes.
start you with Tylenol?
Yeah.
Like the basics before you now even start thinking of
Yeah.
worse
Yeah.
things.
We
And
don't want to
fluid
just
hydration too.
fluid hydration. We don't want to just stick you in a CT scanner. That's not always indicated.
No.
Plus, you're pregnant, and we don't want
Yes.
to do that unless you have to. But if it's
Correct.
needed, it's needed. So we try
Yes.
conservative measures first as well. But the most important thing is have that conversation with the physician so they can kind of tease out, is this different? Is it the same? How long have you had
Correct.
it? What have you done so far? And this
Correct.
goes into the postpartum period as well. So paying
Hmm.
attention to postpartum headaches is just as important as if you're pregnant, right?
That's true. That's
Right.
true.
One of the other things, just while we're on the topic, is if you wake up, if a headache causes you to wake up from a dead sleep, if you feel
Yes.
like you had a thunderclap in your head,
Yes.
if it's this acute all of a sudden and you've never had that before, you have to be checked out because then that could be some of the more serious things that Dr. Nabobi talked about, like an aneurysm or something like that. And
Yes.
that's something that's pretty significant and you have to be seen and you shouldn't put that off.
Correct.
Okay. Let's talk about,
Exactly.
this is one of my favorite ones, changes in vision.
Hmm.
When you think about changes in vision, both pregnancy and in the postpartum period. What do we mean while we tell patients all the time, do you have changes in your vision? And they're looking at me like, what do you mean? So what do we mean when we ask that?
So when you're talking about change in vision, changing your baseline vision, right? Like if you all of a sudden are having blurry vision, I don't even care who you are, pregnant or not pregnant. Yeah. You should be worried about it, right? If you all of a sudden are having a double vision, and another thing we also need to put into this, if you're someone who has prescription glasses, right? Yeah. Obviously, we also need to count into it. Do you need some adjustments? Do you need some resetting? But if all those things are already checked out and you have a change in vision where things are blurry, you have floaters, things of that nature, absolutely things you want to bring up. Because partly now you're mentioning things that could be associated with, again, preeclampsia, all right, a condition we do not want to miss. And also, it can be a manifestation of some kind of intracranial process. So again, something we do not want to miss. So a lot of times, the classic things that, you might expect to see with really bad stuff do present, because common things happen commonly. So again, if you just notice that, I just don't know, my vision is not just the same, again, you want to bring it up. But funny enough, when you have a mom who just had a baby, she's very exhausted, she's not getting a lot of sleep, it can also be maybe you need some rest. But it's fine and okay to just bring that up first and let people around you be aware of it, and also let your providers be the ones to ultimately reassure you about it.
Yeah, as someone who had migraines, my headaches weren't really worse in pregnancy, but I remember I was driving, I was within 4 weeks being postpartum, maybe 6, and all of a sudden lost vision in one eye.
Oh, wow.
Of course, I was a doctor. I freaked out.
Yeah.
So I went to the doctor, and it just ended up being another manifestation of my migraines that I'd never had before. And it might have been due to the changes that I had in pregnancy, maybe some of the fluid shifts, or who knows, hormonal changes that could have made it change. But I definitely went and had it checked out because I didn't know, and I wanted to make sure it wasn't something serious. So yeah, you got to pay attention to those vision changes. If you're otherwise feeling okay, you might want to maybe take a nap, a rest, wake up, see if it's still there. And if it's still there, then you need to definitely go see it. But now if it's associated with other things, with a headache and vision changes.
And vision,
then you definitely don't wait.
Yes,
don't wait.
Now it's adding up.
Yeah.
And I'll throw in something else there too, with the vision change. One of the things that a lot of people do not know about is, a change that can happen after you've had eclampsia, or even as part of preeclampsia, PRES, where sometimes we've had patients who will show up later and they're like, I just cannot see. I will not forget a patient in residency who actually up to 2 weeks, she actually lost her vision. And it was just part of the process of preeclampsia, where you have this cerebral edema, compression of the occipital of the posterior portion of your brain, and all of a sudden it affects your vision. With time, it can resolve. But again, if this is happening, it's definitely something you want to bring up so that, the people who are well versed in this can be the ones to say, nothing to worry about, reassure you. And if you at the same time feel like, well, I appreciate the reassurance, I just still cannot see, then maybe we need to escalate it to someone else or get a second opinion.
Yeah, PRES, it's the proper name is posterior reversible encephalopathy syndrome. It is more commonly seen with eclampsia, but you can have it with preeclampsia, and it's because you're swelling because of the preeclampsia all over your body. The brain is no exception; it can happen. But the tricky part is sometimes if they're on magnesium for preeclampsia, you get double vision anyway. But it's different. Having double vision, but if you can't see or you're losing fields of vision, you got to tell somebody, because that could be PRES. And I've also seen it in the postpartum period. I've also seen retinal detachments from preeclampsia.
I have heard of that.
Yes, I've also seen that bilateral. So your vision, you have to pay attention to your vision. If you're preeclamptic in pregnancy, if you developed it during delivery, then you recover, you go home. Anything that goes wonky with your vision, plus or minus a headache, you gotta go in and be seen. Thankfully, most of the time, it's just a matter of doing some conservative measures in the hospital, monitoring your blood pressures, giving you some things to help get that fluid down, and it usually resolves on its own. But you need to be followed by neurology, and you need to be followed by ophthalmology if it's affecting your vision significantly, especially if there's like retinal detachment. So we do have to get those people on board, because you want to follow it up to make sure it repairs over time. Okay. Next topic, fever of 100.4 or higher. What are we looking in the in pregnancy or postpartum?
Correct. So in pregnancy, anytime you have a fever, Absolutely, you want to bring that up, right? Fever, again, is the body's manifestation that there's some kind of inflammation or infection process going on. Now, the question now comes down to where's the infection? Is the infection isolated to the mom, or is it an infection isolated to baby, or is it an infection affecting both mom and baby, right? So you want to report that because you want to be fully evaluated to know exactly which organ system is involved. And not only that, we want to know if you have an infection, how bad has it become? Right? Are we now talking about you are so sick that you actually need to be admitted in the hospital? You need IV antibiotics. So you definitely want to let that know. One of the things, huge campaign in the health system that goes beyond pregnancy is a sepsis campaign, right? We do not want to have moms that are so sick that they are not being managed in an appropriate setting, such as an ICU, and do not get the appropriate interventions, such as IV fluid hydration, antibiotics. I mean, we could spend a whole day on that. But a fever is definitely that first warning sign that something is going on. Now, in a pregnancy setting, let's say you came in for into labor and delivery for your delivery. Now, a fever can tell us different things, and different things can point towards why a mom is having a fever. It could be an intraamniotic infection. It can also be from a side effect of medications that we give you to help you with the labor process. Now, in a postpartum setting, now that can even point towards things such as, do we have some kind of infection in utero because we have a retained placenta? Do we have actually a blood clot? You know, one of the ways some of the moms can even present with that could be, you know, having a fever. So again, fever is something that we do not want to play with. You know, as a medical student, we always know all the W's of fever, you know, especially for our moms who've undergone surgery. But one of the things you always want to include in that is, you know, womb, and also, you know, with the breast. Can it be that you have some kind of mastitis? But again, a fever is a sign you do not want to ignore, and you definitely want to make sure that you alert a family member or your OB provider, because further evaluation might be needed.
Right. So, you know, as Dr. Nwabuobi said, what we don't want in pregnancy is sepsis. Sepsis is in pregnancy. Sepsis is difficult no matter who you are, but definitely in pregnancy, we don't want that. More often than not, it will require delivery of the baby, even if it's early, because it becomes harder once a patient crosses that bridge into sepsis. And there's a lot of things more commonly that we see as a urinary tract infection that they just don't report the symptoms long enough, or sometimes it happens very quickly enough, or, you know, it just happens so quickly it goes into sepsis. You know, we do a fever workup, figure out where the source of infection is, but you just can't ignore it, because we don't want you to get that sick. It's sepsis. I don't like septic pregnant patients.
No.
It's not my favorite thing. And I know we say that lightheartedly, but we're being serious. You know, you have to pay attention to your body, especially in the postpartum period when you're home with a new baby. You might be a first time parent and you don't understand what mastitis is like. You're having abdominal pain, some foul smelling discharge, where it could be endometritis or infection in the lining of your uterus. So those are all things that you have to watch out for. And it's always better to just call the doc or just go into the labor and delivery triage to be seen and evaluated, just to make sure everything's okay.
Correct.
Okay.
Agree.
Okay. Now, this is one of my favorite: extreme swelling of your hands or face. Now, listen, all pregnant patients are going to get swollen.
Yes.
My nose got swollen, everything got swollen. But why is that an issue? Why do we worry about extreme swelling of the face and the hands?
So there's going to be a recurrent theme in today's conversation.
Yes.
And I think
yes, for sure.
I think preeclampsia is going to be that recurrent theme. So extreme swelling of your hands and face. You know, like you mentioned, a lot of our pregnant moms, they have swelling in pregnancy, which is a normal physiologic change that you see. However, when you have swelling, and you're talking about significant swelling, 3+, 4+, pitting edema, involving hands, feet, sometimes face. I look at a patient, I'm like, you look a little different.
So the best way I figured out how to explain to a patient is, the normal swelling of pregnancy usually happens in dependent areas, meaning your legs, your feet, where gravity pulls the fluid, right? Gravity shouldn't be pulling fluid into your face or your hands, right?
That is
so
true.
If you're getting it in your face or your hands, something's not right. And one of the other things is, if a family member, because you may not notice because you see your face every day, but a family member says, yo, what's going on with your face? It's so swollen. And somebody else notices, then you need to take that seriously, right?
Yes. And that is something that I do because
Yes.
whenever I mention that to the patient, I usually look at their partner and I say,
Yes.
does something look different about your wife, about your girlfriend, about your partner? And they're like, yeah, I just kind of be noticing, you know, but guys, at least the ones that are well trained, are very polite,
Yeah.
and they don't want to
Yeah.
tell their
Yeah,
partner.
they don't want to say anything. Yeah.
Yeah, they don't want to say anything. But you know, at that point, that helps reassure me that I noticed that something is different. Now, with the swelling, one of the things, telltale signs that we could see with preeclampsia is that we have this, you know, swelling of, you know, hands, feet, dependent areas on top of that. Because what happens is that you have this leakage in the blood vessels,
Yes.
in the body, and all of a sudden you have fluid leaking into all these spaces, and then you get the swelling. So if you have that and you have high blood pressure, you have extra protein in your urine, all these things generally warrant that your OB provider should do an extra investigation of exactly what is going on.
And then the other thing too, and this is less common than preeclampsia, because preeclampsia is one of the more common things,
Common
is
things.
heart failure.
Yes.
Peripartum cardiomyopathy, heart failure from having preeclampsia or chronic hypertension, and you get some what we call diastolic dysfunction of the heart, which doesn't allow the heart to pump like it should. You could start retaining fluid. So, you know, we got to look at the heart too, because, you know, we can't just assume it's preeclampsia. So coming in to get evaluated, we got to listen to that heart. We got to make sure it sounds okay and rule all that out as well. Even though peripartum cardiomyopathy is not the most common, it does happen, and we don't want to miss that. And we'll get to the more the lung symptoms in a minute that will go along with that. But you know, that's another thing that we have to think about when you start having the extreme swelling.
Absolutely.
Right.
Absolutely. Absolutely.
Yeah. Okay. The next is under maternal warning signs: thoughts of harming yourself or your baby. You know, that is a something that people don't want to admit.
Yes.
But I want you to listen, and for myself and Dr. Nwabuobi, it happens, and it's more common than people realize and want to admit. It does not mean you're going to harm your baby. It does not mean that we're going to take your baby from you. But what it might mean is you need to be evaluated. You might need to see psychiatry, maybe be started on some medications, have some intensive follow-up, so that you can get those thoughts under control. More often than not, it doesn't mean we're worried you're going to harm your baby. We're worried that your symptoms might go down the path of being untreated to where they get worse, and then something bad does happen, right?
Yes. And you know, one thing I've appreciated, I would say one of the, 2020 brought a lot of bad things, but there's also some positives that came with this year and with last year. And it's the fact that I feel like more people are embracing the idea of addressing mental health.
Yes.
Some of us who have anxiety, who never wanted to admit it or never wanted to even like acknowledge it. 2020 was the year when we finally were like, you know what, there's something that's been going on. I need to admit it. The stigma around mental health needs to be dropped. I think it's on so many levels. But this whole idea of, a mom being able to do it all, take care of the baby, handle their mental health and all that stuff, we need to put it to the side. Moms do not need support only when they're carrying the cute baby and taking beautiful pictures. They need support after the baby gets here. Actually, towards the end of last year, I actually lost a patient who took her life. And she was awesome during the whole pregnancy. I actually found out from the newspaper that she passed away. And so this is something very important because a lot of moms are dealing with this and kind of keeping it to themselves because they want to seem strong. They do not want to seem like a failure to their baby. They do not want to seem like they don't have it all together. Again, especially in times when we are constantly being hit with this super mom, image out there in the world. And so you have a lot of moms who are in dark places who do not want to admit it. The other thing is moms who actually already are in care for a mental health, but all of a sudden, because they are pregnant, the psychiatrist forgets how to care for a patient. I mean, that annoys me a lot when I see our patients who show up and I'm like, okay, so what medications are you on? They're like, oh, it was discontinued. I'm like, why was it discontinued? Oh, because I'm pregnant. No, that cannot happen. You are already setting up this patient for failure because now you've taken the medications off. Now she is in the right mood. Now for her to restart the medication is going to take several weeks to get her back to that level where she was well controlled. Leave the job. If you're not going to take care, I call psychiatrists all the time. Like, if you're not comfortable, tell me what it is. I have safety profile. I use reprotox.org. Mother to baby.org is something I'm also, I use a lot of. and I reassure the patient, let me be the one. Say that you spoke to the MFM, put my name on it,
Yes,
just to get the patient. So, but
yes.
again, it's a big topic, but moms, everyone listening, everyone who's going to listen, if at any point you do not feel like you are yourself, you feel like harming yourself, please speak up to someone,
Yes.
family member, call your OB provider, let them know these are things that we take very, very serious in this specialty.
Yeah, and thank you for saying that, because I educate about, and I actually just posted a video about this yesterday, I believe, about taking medications off.
Yes.
The knee-jerk reaction is to just stop the medication. If someone needs treatment with the medication when they're not pregnant, there's nothing magical about the pregnancy that where it all of a sudden goes away. The only reason why people are doing this is because they don't want the responsibility because of the pregnancy. And yes, I know everybody wants to protect their baby and do everything they can, but a healthy mom, if that means medications of any sort, whether it's antidepressants, anti-anxiety meds, insulin, blood pressure medications, blood thinners.
Yes.
No one would think twice about any of the others, but when it comes to antidepressant, anti-anxiety meds, bipolar meds, everybody thinks we can't. We have to get out of that mentality.
I agree.
Because it's not worth it. It's not worth it. It's not worth it to have an untreated mom. So anyone that's listening, whether you're a healthcare provider, if you're a healthcare provider, please get out of that mentality of telling your patient to stop the medications. If you're a patient, there's nothing to be ashamed of. No. I went through it too. I had intrusive thoughts when I had my twins at home. There were times where I couldn't even get out of the bathroom because I was such an emotional wreck. But I'm a physician, and I knew it was going on, and I talked to somebody about it. But if you're not, and it scares you, and you think they're going to think I'm a bad mom, or I am a bad mom because I'm having those thoughts. That's not what it is at all. It's more common than people think. Yes, go ahead.
Yeah, let me just add something. I also think that, I see a lot of gender reveal videos, baby shower parties. I see they always talk about it takes a village to raise a child. And I see this village all the time when mom is pregnant.
Yes.
Where is the village when the mom has the baby, right?
Yes.
I grew up in a culture where it was a lot of attention is given to mom when the baby finally shows up. I feel like we need to normalize that. Yes. Do not disappear because the baby's here now. No. Yes. All you guys who showed up to the baby shower, all you people who showed up to the gender reveal, please show up to that mom. Call her every day if you can. Just say, how's it going? How's the baby doing? Do you need help? Moms appreciate things of this nature, and we do not know where mom's mood is at the particular day when you call and put a little smile on her face, and how it could change whatever thought she has. So let's be there, not just during pregnancy, but also after pregnancy.
I completely agree. And I think it doesn't take a whole lot to make a big difference in that person's life as a new parent. Yes. It really doesn't. A little bit of effort can go a long way and can change the outcome for a lot of these new parents.
Absolutely.
Okay, so moving on to the next urgent maternal warning sign: trouble breathing. We talked a little bit about this one already.
Yes.
And I get this question a lot.
Yeah.
I'm pregnant. I'm already, and yes, when you're pregnant, you do have a higher resting respiratory rate. You do get more winded as the further along you get when you're going up a flight of stairs. So how are they supposed to know that it's pathologic or that it's abnormal?
Yes. So what I try to use, because this can be a little tricky one, in particular, the trouble breathing one. So what I try to say to patients is, I feel like I say this every day, I've already said it twice today, are you having more trouble breathing from what you have been experiencing this pregnancy? The ones when they say yes to me, I say, what were you able to do before that you are not able to do now? They tell me, I'm like, okay. I'm like, are you needing more pillows to sleep? They tell me. So I put all these things together, and I'm like able to say, we kind of need more evaluation, and obviously with a little bit more focused physical exam to go with that. But this could be tricky just because again, like you said, a lot of our moms are winded, they're pregnant, they're exhausted, some have 2-3 jobs, so it's trying to add a little bit more information and put things in context to be able to assess, this is a mom I'm worried about. I look at the heart rates, I look at lower extremity, looking for signs of like a blood clot, looking for signs of swelling, just because trouble breathing can again be manifestation of different organ system being involved, but particularly cardiopulmonary in that case.
Yes, so. And if you don't know, just ask. Pay attention to your symptoms, and a lot of this boils down to paying attention to your body, so you know that something's changed. Yes. And I know that's hard to do, especially later in pregnancy, and especially in the postpartum period. But we have to educate our new parents that they have to try to do that.
Yes.
We have to, so that we know when something's not right. And this is one of the things. And, needing more pillows. One of the most common things, they usually sleep on 2 pillows and propped up, and now they're sleeping on 4, or they're having to sleep in a chair now. That's not normal in pregnancy.
It's
Okay.
not.
So that's what we mean by you have to sleep sitting up, or you have to sleep on more pillows or propped up. That's not normal, and that should be evaluated. And going along into the next one, chest pain or a fast beating heart.
Yes.
The shortness of breath can be accompanied by chest pain, and it can be accompanied by a fast beating heart. Let's discuss that a little bit. What could be going on with if you're having also chest pain and a fast beating heart, or palpitations, like we call it?
Yes. So, chest pain, fast beating heart, I usually think of cardiac related stuff. But at the same time, it can also be a pulmonary, like a blood clot. It can also be extra fluid in your lungs. I mean, I just think generally cardiac and pulmonary pathology. It can also be anxiety. Okay. I've also, have patients present with that. But when you're really talking about true pathologies that can cause harm, you definitely want to make sure that you have conversations with the patient about recommending things like an EKG, if anything, just to start with, just to look at that heart rhythm and see is it pointing you. I think it was about a few weeks ago, one of our hospitals, we diagnosed the mom with new AFib, atrial fibrillation, for the first time, right? Who would have thought? But knowing that a lot of times women might not present with the classic symptoms that men have for myocardial infarction or heart attack, we definitely should be looking for these other subtle things, because that could also be the woman's way of having a heart attack. So when a woman is coming in telling you chest pain, heart beating fast, you want to look into it a little bit more. The heart can also beat fast. I know I've mentioned this before with a blood clot, right? Chest pain, heart. I've had moms, who've had massive pulmonary embolism. And one of the ways they presented was having chest pain, the shortness of breath, their heart rate being fast. And you do a bedside echocardiogram, and there's a big clot sitting right there and putting a strain on the heart. So again, definitely not something we should take granted for. In this case, I would not even think too much. This needs further evaluation.
Yeah, and one of the things that we have, a lot of abnormal heart rates or cardiac arrhythmias are uncovered in pregnancy because the heart muscle gets distended due to the volume of blood, and the heart gets bigger. And so they could end up with AFib. They could end up with SVT. They could end up with some PACs or PVCs. Some of those arrhythmias are more benign than others. And, it takes an EKG or sometimes a Holter monitor to figure that out, depending on what the rest of the symptoms are. But there are some physiological things with pregnancy and the actual heart that causes some patients to get cardiac arrhythmias. And again, they're not all going to be bad, but we don't know unless we check it out. The other thing is reflux is a very common cause of chest pain.
Yes, I saw that coming down the
Yeah, reflux. Yeah, they mentioned it. Reflux is also, and it's fine. It's fine if you get there and you think you are having chest pain and a regular heart, and it just turns out it's reflux.
It's okay.
That's fine. That's fine. That's great. But we just want to make sure it's nothing else. There was one other thing I wanted to make sure, the reflux, but the bottom line is this, if you're not feeling well, you're having some chest pain, shortness of breath, fast heart rate. You also mentioned this, the anxiety. We can't, as providers, just say you just have anxiety. How do we know unless we
do we know?
Because there's not a lab test, there's not a physical exam test for anxiety. So it's kind of, in my mind, in pregnancy, that is a diagnosis of exclusion. We have to rule out the other stuff first. We can't just assume it's anxiety. And also, patients with a history of anxiety will get labeled with that too.
Immediately.
She has a history of anxiety, so it's just anxiety.
It is anxiety.
What if it's not?
Yes.
What if she has anxiety and SVT? Or what if she has anxiety and AFib? What if she has anxiety and a pulmonary embolism? As providers, we can't just assume. We can't, right? Right.
That's true.
I mean, it is. You can't. We still have to do our due diligence and do the workup. We have to do the workup. Okay.
Yes.
Let's talk about severe nausea and throwing up. What would we have to worry about? Like, if you're having that, what could be some of the potential consequences when you have that severe nausea and vomiting and throwing up?
Yes, so severe nausea and vomiting, throwing up. Again, it could, a lot of times people would think, oh, I'm just having more of my nausea and vomiting in pregnancy. I had it in the first trimester, now it came back. Again, you still need to let someone know because generally in medicine, we have a general concept of how to evaluate someone with coming up with nausea, vomiting, right? We're looking for any kind of gastrointestinal process going on. Is anyone around you sick? Are you the only one sick? How long have you been having this for? Are you having, is there kind of a blood coming with it? Like there are all these different things that we want to seek out from you to help us characterize, is this a benign or is there some kind of pathology associated with this? But you got to let us know. I've also seen patients who had a brain mass. Who one of the
I
ways
had
they
one.
presented,
Yeah.
okay, one of the
Yeah,
ways they
I did.
presented was really bad nausea, vomiting, that they just kept complaining. In this
Mm-hmm.
particular case, one of them also had a headache. But
Yeah.
again, when you are having severe nausea, vomiting, consistent, not resolved by the typical things that will normally offer pregnancy, please speak to someone
Yeah.
because that could be a manifestation of something really bad.
Yeah. And then also more typically, you could get severe dehydration, which can throw your electrolytes
Yes.
off balance, which could cause your
Yes.
potassium to go low, which can cause you to
Mm-hmm.
start contracting because you're dehydrated.
Yes. Yes.
If you're diabetic and you can't take your medications and you're type 1 diabetic, you can go into
Oh,
DKA. So,
yes.
severe nausea and vomiting, especially earlier in pregnancy, I feel like, we just attribute it to nausea and vomiting pregnancy or hyperemesis
Pregnancy.
gravidarum, but it can get pretty bad even later in pregnancy. And we
Mm-hmm.
still have to, let's go back to the hyperemesis. People that
Yes.
have true hyperemesis, it's sometimes it can last the whole pregnancy. And the bottom, what we're trying to do is get you to a point. We're probably not going to get the symptoms completely away, but they need to be manageable to where you can still live your
Yes.
life. You can still maintain some
Yes.
hydration, some intake.
Mm-hmm.
But if it gets to the point where, you're later on in the pregnancy, you just can't keep anything down, you're definitely dehydrated, you're having these
Mm-hmm.
we've got to get that addressed because we don't want it to turn
Yes.
into something worse. And
Yes.
I'm sure you've seen it too. They come in and they're contracting every 2 minutes
Yep. Yep.
because they're so
Absolutely.
dehydrated. And
They're
then also
dehydrated.
and the DKA, they're not able to
Yes.
take their medicine. Next thing you know, they come in and their sugar is 400. So
Yes.
severe nausea and vomiting in pregnancy is not something to be, is it can be serious and we have to treat it as
Yes.
such.
And I'll just throw one more thing too. I like the DKA. The DKA is huge because
Yes.
whenever you have a type 1 diabetic, even type 2 diabetics have a form of
Yes.
DKA. But the other thing
Yes.
is thyroid
Yes.
disorder. I
Thyroid
will
storm.
never forget
Yeah.
a
Yes.
thyroid storm. And the only way she presented was severe nausea, vomited. And I remember saying, when was the last time anyone checked? She's like, oh, I'm not sure. And I checked it. I mean, I remember calling the endocrinology fellow to, he was in his garage. He turned around because it was so bad.
Yes.
So
Yeah.
again,
Yeah.
let us know and let us be the ones to reassure you and tell you. And I know people get worried, but I've been to triage how many
Yeah.
times? It's our job. Let
Yeah.
us be the ones to reassure you.
Yeah. Next one's going to be severe abdominal pain that doesn't go away. What will we be worried about?
So severe abdominal pain that doesn't go away in pregnancy. I mean, the list is a lot, but
Mm-hmm.
definitely you want to make sure you characterize it to us exactly where it is, because now we start to think of, you're talking about from things from appendicitis
Yes.
to urinary tract infection, blood infection, all the way to things that is affecting the baby, placental abruption. You're talking about uterine rupture. You're talking about actually labor. We still have to
Yeah.
include that in
Yeah.
there, right?
I had it yesterday. Just
Oh,
real quick, I
okay.
had a 29-weeker who came
Okay.
in, who had just been discharged for abdominal pain. She came back
Yes.
in. She could barely stand up straight, but
Hmm.
she kept pointing to one, and it's unusual. There was one spot on her abdomen,
One
and I was like,
spot.
well, maybe she has an incarcerated hernia or something because she's had a previous
Yes.
C-section.
Yes.
Turns out she was in labor.
Oh,
She was in
wow.
preterm labor. But you gotta take the time to work it up and see and how it plays
Yes.
out. Because a
Yes.
lot of times, unless you do that full workup and you actually talk and you watch, we literally
Yes.
sat in the room. I was in the room off and on for about an hour just watching to see
Hmm.
what she was doing when she was having this pain. The next thing you know, she was in preterm
Yes.
labor. So yeah, I mean, a lot of times it can be just from labor, but it may not present, or they may not realize that's what it is because
That's what it
they
is.
don't see it that as contraction pain, right?
Correct.
Yeah.
And then you could go up to things like, GI stuff, small bowel obstruction. You could even
Yeah.
go back to pregnancy. Now you start talking about specifically, we always say right up quadrant abdominal pain. You think of like preeclampsia,
Yes.
but then now there's a lot of people who present with abdominal pain, and it's not necessarily right up quadrant abdominal pain, but they
Yes.
still have preeclampsia.
Yep.
So again, the scope here is pretty wide, but the main thing comes down to evaluating the patient, because then you are able to now get more narrowed down to what is the most likely cause of what this patient has here.
We had a case a while, not too far back. I had a really, I won't go into details of it, but we were discussing it with my division director, and he said to us, he goes, if you take the time to talk to the patient, they will tell you what it is. If you listen and you formulate the timeline and you listen to what they're telling you and you take the time to ask those questions, they're going to give you the information to make the diagnosis. Right?
Yes. I had an attendant, an emergency medicine attendant when I was a medical student, who I was very fond of, and he will always say 90% of the diagnosis is from the patient's history, like what they tell you, what you're able to say to them. And I think that still holds true. You know,
it is true.
I've seen people sound frustrated, but I don't know what's going on. This. And I just walk into the room, I pull a chair, I sit down, I say, so tell me. But I walk and I'm like, this was going on. But they're like, what? She didn't tell me that. But again, you gotta ask.
We, you know, we're in a day and age where we have CT scan, we have labs, we have the computer, and you cannot diagnose a patient from a computer screen.
No,
you cannot diagnose a patient by just sticking them in a CT scan. You have to talk to the patient. And you know, in academic medicine, you have to teach the residents that they have to pull up a chair and talk to them.
Talk to the patient.
Talk to them, ask questions, and they will tell you. If you really take the time to do it, you will figure out what's going on with them. Okay, some of the other things, let's see. We talked about babies, if it's not moving, babies not moving like it should. You know, that's always something to think about. You know, everybody's child has different movement patterns, but if you're ever worried that the baby's not moving like it should, it's always something to call for, right?
Absolutely. Yes.
Yeah. And then obviously vaginal bleeding or leakage of fluid in pregnancy is always something to call for and should not be dismissed at any gestational age, even earlier on, because you can still break your back early. You can still have bleeding early. Okay. And then increased vaginal bleeding, especially in the postpartum period, you have to pay attention to that as well. You know, so I kind of went through some of these quick because I wanted to get to another topic before Dr. Nwabuobi has to go. But, you know, these are all on the CDC, and I'll list them under my stories today and also under my highlights. And I'll send them over to Dr. Nwabuobi too, and you could share as well.
Thank you.
But there's a bunch of them to go through, and so that's that. Now, the next thing I wanted to talk about is maternal mortality. Yeah. You know, basically, here's a few stats. Over 700 women die each year in this country from problems related to pregnancy or delivery. Two-thirds of pregnancy-related deaths are preventable.
Yes.
Just let that sink in, 2/3. 2 out of 3 women who are dying in this country from pregnancy-related complications could have been saved. That's what that's saying. Yes. As many as 50,000 women experience severe unexpected health problems related to pregnancy that may have long-term health consequences. Okay, so why? This could be a whole other conversation.
I will add 5 more minutes. Let's really dive into this a little bit more because this is important.
So you know, what can we do as doctors? What would you say to a provider? If you had a physician in front of you who's taking care of pregnant, what would be the one piece of advice you would give them to help improve this? And then what would you say to a patient?
I think for a provider, let me start with that, and I will go to the patient. I think for a provider, I think the whole point of today's live discussion really comes down to what I want to say, which is to listen to your patient. And it, again, this is not, because I was thinking about this talk today. I was like, you know, I hope whoever listens to this later, especially providers, do not think this is a bashing session, because that's not what we're doing. And every single one of us have a room to do better in all that we do. I think that we just need to listen more, because when you dive even deeper into this, into the statistics, you also see that a certain population is more affected than the other. And let me just throw out the stats here. Let's go for it. Considerable racial ethnic disparities in pregnancy related mortality exist, and this is just from 2014 to 2017 alone. 41.7 deaths per 100,000 live births from non-Hispanic Black women. 28.3 deaths per 100,000 live births from non-Hispanic
American Indian or Alaska Native women. Then we go to 13.8 for non-Hispanic Asian or Pacific Islander, 13.4 for non-Hispanic white, and then 11.6 for Hispanic or Latina. So American Indian, Alaska Native, and Black women are 2 to 3 times more likely to die of pregnancy-related causes than anyone else.
Yes.
So
And
let's just call it what it is. What is
yes,
it?
Exactly. So now you're talking about there's an issue of one implicit bias and there's an issue of systemic racism.
Yes.
I want to say this. I don't think any one of us went to medical school, right? Spent all these years of training and decided to show up and hurt moms, right? Or decided to show up and discriminate. The issue of implicit bias is so important. And I've seen, conversations where a lot of physicians are like, I don't believe in that. It's true, because when you look at the environment you drive home to every day, when you look at the media you expose yourself to, there are certain narratives that are constantly being painted about a certain population, or group of our population.
Yes.
And so you live being fed this every single day, and you show up to work. There is no way, if you're very honest, that a little part of you doesn't get affected by some of this information, by some of these exposures that you are constantly, being having access to. So implicit bias doesn't mean you're a bad person. It just means you're human, because all of us got one for different reasons. Yeah. So as long as we acknowledge that this exists, it makes us a little bit more aware when we find ourselves in a situation of taking care of these patients, to say, okay, let me not let this kick in, and let me be aware of this, and let me listen to what she has to say. We also know that class does not control for this stats that you just said, right? We know when you go to the CDC Hear Her Campaign website, you could see stars. I mean, one of the women there is Phyllis, who my wife is a huge fan of.
Yeah, Allison Felix, one of the track stars, yes.
Correct, and then you start talking about people like Serena Williams. These are very wealthy people, right? Yep. But them being wealthy did not protect them from some of the adverse outcome that is just there because of who they are and what they look like. So I think listening to your patients, acknowledging their concerns, and being willing to follow through in investigating exactly what is going wrong will be an advice I'll give to a colleague.
And what about to a patient?
To a patient.
Or to a person of color who is pregnant, what would you say to them? Because listen, what I don't want to do is make this a conversation that we're putting it off on the patient and it's their responsibility. However, they still have to advocate for themselves until this gets better, and we still have a long way to go. So what would you say to a patient?
So I right before the last patient I saw before we had this is a patient. She is from a West African country, and she has a huge right lateral fibroid, very painful, very symptomatic. I just saw her, the sonographer presented her to me, said, I could not even complete the scan. She is so uncomfortable. Now, I walk into the room and I said to her, I was like, you just had an appointment with your OB provider yesterday. So what happened? She could not, she's like, nothing happened. I was like, did you discuss it with the OB? She's like, yeah. I was like, so what did you rate your pain? Her husband spoke up and said, oh, she told the doctor that she was fine. I was like, no. Yeah. I was like, okay, mama, listen, you need to open up. Tell the doctor what is going on, right? Because if you do not, yes, can there be a language barrier issue, this particular case? Yes. But again, express. Patients, be your own advocate, honestly speaking, right? Like, because a lot of times it's not like people are intentionally trying to hurt you, but it's because people might not necessarily be all in there to connect with you. And so you sometimes have to do that extra step to say, okay, this is what is going on. Even though we are not the biggest fan of Dr. Google, but this is what I saw. Do you think that there could be a connection between this and this? Because I've been having this persistent headache. I've been having this worsening swelling. I've been having this worsening shortness of breath. And that physician, that OB provider can look and say, okay, she's putting this, let me look forward into this because of how much you have advocated for yourself. So patients, please try and also make that extra step of saying, what could this be? I want someone to know about this. Let me inform them. If it takes me 10 times, I need an answer.
And one of the things I tell the residents all the time is that, sometimes I think and this might go along the implicit bias narrative as well. We think that because we're giving equal health care. I have 10 patients in 10 rooms. They all have just $20,000 They're all equal. I didn't
Equal.
discriminate, right?
Yes.
So I'm
Yeah.
doing my job.
I'm doing my job.
I'm done. Room 1 has
Yes.
10,000, I'll go to room 10. But in room
Yes.
3, there might be a woman from West Africa who has already not had access to prenatal care, who might have chronic hypertension. $20,000 is not going to be enough for her.
No.
Who's been scared to go to to be seen by a physician because of her negative experiences in the past based on systemic racism. So she's entering that room already at a disadvantage, and she may not that $20,000 is not going to be enough for her.
Yes.
Whereas this patient in room 1 is me. I'm a white woman. I got twins. I had a complicated pregnancy, but I'm going to be $20,000 and I'll be fine because I've had access to medical care. Right?
Yes.
I have never experienced racism in medicine. We have to be equitable, and we have to acknowledge it. We have to acknowledge as providers that I think one of the things along the same side, we think that because we are so educated and we dedicated our lives that we're above being racist.
Yes.
We are above having bias because I have this many degrees behind my name. Well, you're not.
You're not.
And until people acknowledge that about themselves, it will never change. We can publish 20,000 papers. We can have 20 stats from every year, but until we as individuals change that and acknowledge it and do better, nothing will change.
Exactly.
Nothing will change.
Thank you.
So, I'm going to let you go because I know you have to go, but I appreciate that. We need to do a part 2 on health disparities in general because we have to have people speaking up. For people to understand, and it goes on the provider and on the patient. We have to make providers understand this is happening. We have to give the patients the tools to advocate for themselves, and that it's okay to advocate for yourself.
Yes, it is okay.
Right?
It is okay.
I thank you for your time. Do you have any parting words, any other words of wisdom, sir?
First things first. Thank you so much for this opportunity. It's always beautiful seeing connections like this. Someone like you have a very huge platform. You are doing amazing things to give opportunities to, those of us who are up and coming, who have the same mission of spreading, the good news to our patients. I really appreciate you giving me this platform. And to everyone who's listening and who's going to listen, all the OB providers, from your maternal fetal medicine specialist to your obstetrician gynecologist to your family medicine doc who does obstetrics to the midwives, name it, all of us are here for you. Some of us need extra, help with educating us about what you need.
Yes.
Okay. We do not know it all. And please speak up, be your own advocate, get everyone in your family part of your care. Because you do not know the one person who's going to notice that thing that is going to change your life and is going to save your life. So we are here for you, and continue to teach us. I believe you guys are the best teachers. We learn from you. We got this far because of the patients. Without the patients, we will not be here. So I appreciate you. And again, really appreciate this.
And tell everybody how they can find you on Instagram.
Yes, follow me at Chinedu Care MD. For anyone listening from Ohio, Columbus, Ohio, I am a maternal fetal medicine doc at Mount Carmel Health System. I'm here for you guys. Thank you so much.
So if you're in the Columbus, Ohio area, go see Dr. Nwabuobi. This is him, Perinatal Care MD. You can get all the information in the caption under this video. Thank you so much. Have a great day.
Thank you. Thank you.
Bye-bye.
I appreciate it. Bye-bye.